Hi everyone, my name is Linson. I work in the hospital as an oncology nurse. This presentation, I'm going to talk about blood investigations in cancer diagnosis through a case study. Firstly, I'm going to talk about the use of blood investigations in oncology and its importance. Then I will discuss a case where the patient's cancer diagnosis was confirmed by blood investigations. We will go through some of his blood test results and have a little exploration between the normal and abnormal readings. Finally, the cancer subtypes, risk factors, and pathophysiology. Blood tests play an important role in diagnosing and treating cancer. Not only are blood tests useful in determining overall health, including kidney and liver function, but the presence of certain chemicals and proteins in the blood can also help diagnose cancer. It is reported that early detection with an effective screening, including blood investigations, can reduce cancer mortality and increase the survival rates. Also, with the current blood results, treatments are guided and critically supported by evidences. It is known that early blood screening can enable the treatment for cure in some cancers. In this case, we will look at patients' FBE, CRP, and cell immunophenotyping results. FBE refers to full blood examination, or sometimes is called complete blood count, which I believe we are all quite familiar with. The test is used to look at the numbers, types, and the sizes of different cells in the body, such as hemoglobin, white cells, platelets, neutrophils, lymphocytes, and etc. Another blood test we are familiar with here is CRP test, which refers to C-reactive protein. CRP test indicates inflammation or infection in the body. Okay, the next one probably is not familiar to many of us, the cell immunophenotyping test. It is a cell identification using antibodies to cellular antigens, including T and B lymphoid, myeloid, platelet, natural killer, stem cell, epithelial, and other non-hemopoietic cells by flow cytometry or immunoenzymatic techniques. It is used to assist in diagnosing a specific type of leukemia or lymphoma. Now let's take a look at the case. For confidentiality purpose, the patient is called Mr. K. Mr. K is a 75-year-old Caucasian male presented to the hospital with fever, coughing, shortness of breath, chills, and chronic fatigue. Patient reported that he had lost 5 kilos in the past month without trying. Bruises cited on arms, legs, and around the body. Patient looks pale, currently on antibiotics for recurrent skin infections. Blood tests performed with GP show significantly abnormal readings in white cells, platelets, red cells, and neutrophils. GP referred Mr. K to see a hematologist, who then admitted the patient to the hospital for further management. Patient had a medical history of hypertension, type 2 diabetes on diet control, osteoarthritis, and GORD. Mr. K lives with his wife and son. He drinks averagely 2 glasses of wine a day and never smokes. Mr. K has no family history of cancer diagnosis. Mr. K was sent for a number of blood tests after admitted to the hospital. Here we only look at FBE, CRP, and immunophenotyping results as critical supportive evidences that lead to the final diagnosis. The FB results indicated elevated white cells with low red cells, low hemoglobin, low platelets, and low neutrophils. The results well explained the signs and symptoms that Mr. K presented on admission. Pale looking due to low red cells, shortness of breath due to low hemoglobin with low oxygen in the body, bruises linked with low platelets, fever and chills associated with low neutrophils. Mr. K is both thrombocytopenia and neutropenia at this stage. The myeloblast cells are immature cells in the bone marrow to develop into neutrophils, monocytes, lymphocytes, and erythrocytes. When blast cells goes wrong, it will fill up in the bone marrow and expand to the peripheral bloodstream. The blast cell ratio is a critical indicator pointing to the diagnosis of acute myeloid leukemia. As mentioned previously, CRP test is used to detect inflammation in the body by testing the level of C-reactive protein. Mr. K is reported to have recurrent skin infections on antibiotics, and this is also indicated by the results of CRP test. It is aware that patients with acute myeloid leukemia can have persistent infections. This is also one of the symptoms that Mr. K presented on admission. In order to confirm the diagnosis and provide targeted treatments, the oncologist ordered cell immunophenotyping test for Mr. K. It is used to assist in diagnosing a specific type of leukemia. Immunophenotyping by flow cytometry shows positivity to MPOB, HLA-DR positivity in combination with CD33, CD13, CD34, and positivity in combination with CD117. These are all immunophenotypic markers used to classify the specific type of leukemia. AML was traditionally classified into subtypes M0 through M7 based on the cell line and maturity of the cells. This was determined by how the cells look under the microscope after a series of special staining techniques. As a result, Mr. K is diagnosed for acute myeloid leukemia stage type M2. And at this stage, maturation of the bone marrow cells is beyond the early granulocyte stage. Varying amounts of granulocyte maturation may be observed. Acute myeloid leukemia is the most common leukemia among the adult population in Australia and accounts for about 80% of all cases. It is characterized by clonal expansion of immature blast cells in the peripheral blood and bone marrow, resulting in ineffective erythropoiesis and bone marrow failure. The cause of MAL in children and adults remain unknown, but increased or decreased risks for developing AML have been associated with several factors such as aging, smoking, certain blood disorder, genetic syndrome, occupational exposure to radiation, and certain chemicals such as benzene. Radiotherapy and chemotherapy for a wide variety of diseases have been linked with moderately increased risk of AML, although the benefits of treatment far outweigh the risks. With recent advancements in the management guidelines, the cure rates have increased up to 15% in patients older than 60 years and about 40% in patients below 60 years of age. Despite advancements in therapeutic regimes, the prognosis remains very poor in the elderly population. As a nurse providing care to Mr. K, I will definitely pay close attention to monitor patients' vital signs, which gives critical information when interventions are required. Due to thrombocytopenia, Mr. K gets bruises easily. Appropriate protection will ensure the skin integrity and minimize opportunities of bruising. By doing this, long sleeves clothes and pants are recommended, combined with utilizing of tubing grips, if necessary. Patient having leukemia is usually associated with neutropenic conditions, where neutrophils level is low and infections and sepsis are more likely to happen. Patients with acute leukemia are highly susceptible to infectious diseases due to factors related to the disease itself, factors attributed to treatment, and specific individual risk factors in each patient. Sufficient nutrition intake plays a key role in treatment and recovery. It is reported that patients with AML with good nutritional status undergoing induction chemotherapy have a shorter hospital stay and longer survival. As part of nursing interventions, providing patient education and emotion supports can effectively relieve negative emotions and promote the development of positive coping styles during the treatment. I will create a private space for Mr. K and I to have a discussion regarding any concerns he may have and provide education where necessary. Thanks for watching the presentation.